Good afternoon, everyone. Thank you for joining us today. I am the Charlie Breznicki, Clinical Director at Blacktree Healthcare Consulting, and along with me I have Robbie Thunderberg, one of our Coding Oasis managers, and we're going to talk with you today about aligning face-to-face documentation to ensure compliance. Before we get started, just a few things I wanted to mention, a couple of housekeeping items. There is a note in the chat if you're having any issues with the audio or being able to hear us, that we're too quiet or so. Check that, and that should be able to help to guide you through get that audio straightened out. Additionally, the handouts are available in the download section. You can download those. And they will also be sent out in the morning along with a recording of the session. Finally, there is a Q&A bar. Feel free to enter in there any questions that you may have, and we'll address those as we have time at the end of the presentation. So we're going to get started here. One other thing, we're going to have 3 polls throughout this. So we will mention them before we get into them, and we do encourage responses as best as you can. So just to give an overview of what we're going to discuss this afternoon, we're going to give a background of face-to-face, what are the requirements around that as well. We'll discuss the various referral sources and the types of the documents that you'd expect. Then we'll get really into the meat of what we're here for, is just the focus of care and how we can align the documents that we receive with the focus of care that we're going to be doing for home health. We'll discuss briefly how face-to-face is still one of the big reasons for the denials of claims and ADRs, and then some of the best practices around ensuring compliance. So as we move forward, these are all the topics that we will address. But before we dive into that, we did want to start out with a poll question, which you should see on your screen. Great. So we'll give everyone a few seconds more to answer that, and then we'll get right into it. All right, hopefully everyone had a chance to answer that question, just to give a little bit of a background. So diving into this about face-to-face. The face-to-face was originally released, it's been just about a decade now, in 2011 as part of the Affordable Care Act. At that time, when it was initially released, there was not a specific form that was required, but there was a narrative that was required. So that narrative had to describe the patient's clinical condition to support homebound status, as well as their need for skilled services. After some time in 2015, CMS changed the requirement, so it wasn't a narrative anymore. What they did require was the actual clinical and encounter note from the provider. So the discharge summary or progress note, or maybe an H&P if that's all you had available, but it was the actual note which had to help to justify the patient's need for home health. And in that time, the past 6 years, that has been a bit of a struggle that we've seen, making sure that what is in that note helps to support our need for home health. So the requirements of face-to-face: the patient must have a face-to-face encounter with the physician or the non-physician practitioner, and we'll discuss who those are in a bit. It must have occurred 90 days prior or 30 days after the start of care. As much as you can, you want to have it occur before the start of care, rather than just trying to track that down, chase it down to 30 days afterwards. Additionally, if the encounter is with a physician or NPP who cared for the patient in the acute or the post-acute facility, it's expected the patient was a direct admission to home health from the facility. CMS has not indicated the time frame there, whether it's 5 days, 48 hours, whatever it is, but the patient, it must be right from that facility to home health. So a discharge summary from the last time the patient that was in the hospital that occurred 60 days before the start of care, it may not be accepted. sure, it's within the 90 days, but the patient was not a direct admission from a facility to home health. So a reviewer may be looking for some additional information if that is the encounter that you used and it did get pulled for review. Additionally, I know this is a lot here to read, but there are situations when the physician orders home health, and it's based on a new condition that wasn't really evident in a visit or in the encounter note that occurred in the 90 days before the start of care. So you may have this note from the 90 days prior to the start of care, but the patient had a change in their status, and that's why they were ordered home health. And that encounter note may not be sufficient. So if the patient saw the physician or NPP 90 days before the start of care, but the reason they're referred for home health isn't really addressed, another encounter would be needed if the patient's condition changed to the extent that the standards of practice would indicate that the physician or the NPP examine the patient again to establish a more effective treatment plan. So they may have had that visit 45 days ago. They're referred to home health. It's prudent to try to get another visit to further support the need for home health, even though that did occur within the allowed time frame. And we'll discuss this in a bit more detail as we get into the focus of care. And that's really one of the key things, is making sure that that encounter note aligns with the focus of care and what we're doing in the home. The documents, so what's actually required, it's the actual clinical note from the face-to-face encounter visit. It should include an assessment of the patient, and that should help justify the referral for home health and support the skill need. It must also be signed and dated. So that assessment is really a key piece there to help to support the need for nursing therapy, really to help to support why we're in the home. So the patient has pain, they have weakness, a short of breath. That helps to support the need for nursing in there to help to educate with pain management therapy in there, to help with balance or endurance, any of these items there. So that assessment is really a key piece there to support why we need to be in the home. So the documents that typically include this are a discharge summary from the hospital or another facility, or progress note if the patient was referred right from the physician's office. So those notes should really help to support the need for home health. In H&P, we included that on there because you may get a patient who goes into the emergency room, and that's going to be the strongest note you have. They were in there for 24 hours and then referred out for home health. So an H&P is what you'll have there to use. So best practice, receive these documents at the time of the referral and indicate in your EMR which note will be used as the face-to-face. And we'll get into that in a bit more why, but it's really to kind of call that out so everyone is aware what is being used as the face-to-face. So the providers, we discussed this, the NPPs at the beginning. So who's allowed to perform the face-to-face? The certifying physician, most often this is the physician who is assigning the plan of care. This is the ones certifying them to home health. It could be the physician who cared for the patient in the acute or the post-acute care facility, or like I said, the non-physician practitioners. So these could be an NP or a clinical nurse specialist working in collaboration with the certifying physician, or the acute post-acute care physician if that's where the patient was admitted from. It could also be a certified midwife or a PA working again along with the certifying physician or the physician who provided care in the facility. So the best practice here, make sure the credentials of the practitioner are clearly indicated in that note. I have seen claims that were denied because you were not able to tell who the provider was, whether they are an MD, DO, PA, or PT, or an RN. PTs and RNs, their notes alone will not be sufficient for face-to-face. So make sure it's clearly on there what the provider's credentials are. So the other items that are required are the note must support skill need and homebound. So we'll discuss these a bit here and kind of how it could be seen in that note. So the physician's medical record, it must contain information to justify the referral to home health and support the skill need and homebound. So that's in the note. It's rare that we get a note that says home health for ABC, patient is homebound because of X. So CMS allows agencies to provide additional information from the comprehensive assessment to support this. The caveats here is this information must be consistent with the encounter note. So if the primary focus of care is wound care and there's not a wound addressed on that face-to-face note, it's going to be hard to say that that is consistent with that note. Additionally, the certifying physician must review and sign off on the documents being incorporated into the medical record. So this could be done in several ways. You can send them the whole OASIS, which is an awful lot that they'll need to sign off on, or you can include this on the plan of care, which you're tracking already. So as you can see in our best practices here, we recommend that this be included, and it doesn't need to be the entire OASIS, but just key information from the comprehensive assessment to support the skill need and the homebound status. Include this on the plan of care. And a lot of the plans of care just allow a place in there that it could either be in the goals, it could be in the interventions, it could be somewhere else that is just pulled onto there to support the skill need and homebound status. The plan of care must be signed anyway. So by the physician signing off on that, it indicates they've incorporated that into their medical record. So some examples of skilled care for nursing, wound care, and management, teaching a family member how to perform the wound care, how to monitor for signs of infection, Foley care, how to clean the Foley, management of it, training the family on troubleshooting issues, med management. This is really a key item, especially with the patients that we serve who have chronic illnesses, how to monitor their meds, how to manage their meds, monitor for exacerbations, and then how to intervene to try to keep them out of the hospital. And then additionally, ostomy management and training, how to manage the ostomy, how to protect the skin around there, change that appliance as well, especially for anyone who has a new ostomy. Some of the scenarios that may not be considered skilled: administering oral meds, eye drops, or topical ointments. Going in there solely to set up a pill box or to administer this oral med was not deemed as skilled. Going in there to educate on side effects of a new med, what to watch out for, how to take a med, those are considered skilled. Simply to set up meds, not necessarily. And then also not considered skilled, venipuncture solely for the purpose of drawing blood. We can draw blood in home health, but going out there for a visit only to draw blood, we need to have an additional skill need. Going out there to manage a wound, educate on meds, manage a central line, any of these items are skilled there. And the venipuncture could be in addition to that skill need. So some examples of skilled need for therapy, I've broken down here: PT, OT, and speech. PT may be in the home to provide therapeutic exercises, gait training, range of motion, and even for maintenance. Therapy, maybe we had a patient who was on skill, but now they're going to be on for maintenance. Safety in the home is really a key item here. Improving endurance and ambulation is a big one with PT. For OT, the skilled items: restoring the physical functioning, sensory integrative functioning as well, and then helping them to manage all their ADLs. Trying to get them as independent in the home is really one of the key items here with OT. So having OT involved there to get patients to their highest functional level to remain in their home and safe in their home is a skill need as well. Then lastly is speech language pathology. This may be there's been a change in a functional speech, or helping them to clear confusion, to manage in their meds, to prevent any unsafe behaviors in the home, And then additionally helping patients with aphasia. All these are items that would help to support the skill need for speech therapy in the home. As far as homebound, just a review on this, the document from the provider that face-to-face must help to support that the patient is homebound. It's rare to get a note that says the patient is homebound because criteria 1 is met in this way, criteria 2 is met in this way. We want to see where is this within that assessment. But just as a review of what is the homebound status, criteria 1, either of the following must be met. So the patient requires a device, person, or transportation to leave the home, or leaving the home is medically contraindicated. So the patient is at risk of contracting an illness, they're immunocompromised in light of the public health emergency. Folks who are at risk for COVID could have been deemed contraindicated to leave the home and were homebound for that reason. In criteria 2, both of the following must be met. The patient must have a normal inability to leave the home. So what keeps them from leaving the home? Are they on oxygen, short of breath? Are there a dozen steps that they have to navigate? And then leaving the home requires a considerable taxing effort. If they are on oxygen, do they have to take a cylinder along with them? How do they make sure they have a full tank? How far are they able to get from that home? Must they coordinate a ride, someone to help them out of the home? So this is all considerable taxing efforts to leave the home. That usually this can be seen within a physician's note in that assessment where it indicates the patient's short of breath, or they are confused, or wheelchair bound, or limited ambulation up to 10 feet. Any of these items just helps to support that the patient's homebound, and then elements of the comprehensive assessment can further support that the patient is homebound. The date of the encounter, this is required. So one, the encounter note from which it occurred must be on there so we can tell when the face-to-face actually occurred. In addition, the certifying physician must document the date of the face-to-face. This can be done in several ways, one of which is just include that date on the plan of care. You can send in a separate note asking the physician to sign off on that, but then you need to follow up with that, and that's just a whole other piece of a document that you must track. So in the event the certifying physician performed the face-to-face, by them signing on their note, that's adequate. They signed off on that date. And then in cases where a physician other than the certifying physician who performed that, the certifying physician must indicate the date of the encounter. So CMS provides the following statement. This contains all of these elements from the certification, and the last half of it indicates the patient had a face-to-face with an allowed provider type on, and they leave it blank so that that date can be filled in there. And the encounter was related to the primary reason for home health. It's recommended to include this on the plan of care. This prevents the need for a second form to be submitted and to be tracked, which can help to lead to delays in submitting a final claim. So by having that blank on there, someone within your agency can fill that in, whether write it in, they can have the EMR that automatically populates that date if another field is filled in. So have a look at your plans of care to see if this or a similar statement is on there, and if not, we recommend that this be added onto there. So some of the documentation, this is where we get into the referral sources. Some of the big ones that patients will be referred to home health. There are the acute facilities. These are really the hospitals. What you want to get from the hospital is discharge summary, progress notes, any consultation notes. And for these notes to be accepted, the patient must be a direct admission to home health from the hospital. So there can't be, or if the patient goes from the hospital to a SNF to home health, that hospital note may not be accepted if the patient, simply because the patient is not a direct admission. Then the last item here, the operative notes and the HMPs, they don't typically provide the current status of the patient, especially an operative note. The patient's sedated, it doesn't give a functional loss status. So that most of those notes are not going to be accepted. And H&P, if the patient was in the hospital for several days, it's not going to give their current status. So it's best to get a more recent note or a discharge summary to support why home health is required. The post-acute facilities, so these are your SNFs, your inpatient rehabs, inpatient psych, your long-term cares. Again, for these notes to be accepted, the patient must have been admitted to home health right from the facility. So they can't go from a SNF and then into a hospital and then to home health, and you use the note from the SNF. You would want to get as best as you can that note from the hospital. So again, the preferred notes, discharge, a summary, or progress note that contains an assessment of the patient and the ongoing plan. A lot of the time in a SNF, you'll get therapy notes along with a discharge, a summary, or a progress note. And the therapy notes can be used as a supplement, but the certifying physician has to sign off on that. So they would be included along with the plan of care if you are going to use those to send that in. So it's just be cautious if you are using those, making sure that the certifying MD is aware of those and does agree that with those, and they can be sent along with that plan of care. So the last one here about a referral source, the physician offices. So if you're getting a referral from the physician's office, you want to ask them, make sure that the patient has had a visit along with them. The encounter, it must have occurred 90 days prior to the start of care, or if the patient hasn't seen the physician 30 days after the start of care. So that's really a key thing, is if you're getting that referral from the physician's office, asking them to send over the most recent progress note that includes an assessment and the ongoing plan and helps to support the need for home health. So at this point, we're going to have another poll question here, and then I'm going to hand it over to Robbie to discuss the focus of care and aligning that documentation.
Thank you, Charlie. I'll give everyone just a few seconds to look at the poll question, and then we'll discuss the focus of care and the primary reason for home health. Okay, so earlier in the presentation, we got a question: does the primary diagnosis on the face-to-face have to match the primary diagnosis on the plan of care? And that's what we're going to spend the next several minutes discussing and going through specific examples. We had another question about talking about ICD-10 coding and how that works and how we must align our ICD-10 coding that goes onto our plan of care that we put on our claim, and how all that needs to align with our face-to-face and our plan of care. So getting started, the primary reason for home health. The encounter, the face-to-face encounter, must be related to the primary reason for home health. Realize that that says that it must be related. The primary reason for home health does not need to be the primary reason for the encounter. So let's stop there and give an example. We have a patient whose encounter, what it mostly focuses on is this patient was hospitalized with an acute UTI. But then basically somewhere as a side note, it also mentions that this patient is struggling to keep their CHF under control. They're struggling with diet. Their weight is up some. Our primary focus of the encounter is UTI, but it does have that note that the CHF is exacerbated, or that it's a problem, or that there's a knowledge deficit. In that instance, if the UTI were to say, let's say the discharge summary says that the UTI is resolved, so we can't code that for home health, but we've got that discharge note noting also that while he was in the hospital, there was this issue with the CHF, there's a knowledge deficit, or there has been some exacerbation, then we're clear to use CHF as our focus of care for home health care, even though it's not necessarily the primary focus of the face-to-face encounter. Our best practice is to identify as best as possible the primary reason for home health once the referral is received. If it is unclear, query the referral source for additional information and additional clarification. To start on some common issues that we see in our RCD reviews and in our coding and OASIS practice, where there are issues with alignment of the primary diagnosis in the face-to-face encounter. The first one of those is that the face-to-face encounter does not mention any acute, new, or exacerbated conditions. And we see this quite a bit. And this is one of the things that Charlie was mentioning earlier, or that he alluded to. So you have a patient, for instance, that the face-to-face encounter note that you get is an annual wellness visit. And that visit states that all of the patient's conditions and diagnoses are well controlled. There's no new medications or medication changes. Refills are given. Everything is great, grand, and wonderful. Most of the time, our Medicare annual wellness visits, the physicians will now address the patient's ability to perform their ADLs and to obtain their medications, that kind of thing. So this is a wellness visit, and at the time of this wellness visit, everything was wonderful. The physician notes no exacerbations, no new diagnoses, no medications or treatment changes. And that's what we get as a face-to-face. The reason for the referral is that 3-4 weeks after the doctor saw the patient had a significant number of falls. Their caregiver calls the doctor and says, hey, can we get physical therapy in here? My family member, my loved one keeps falling. What we have there is a face-to-face and primary diagnosis misalignment. We are going to need, in that example, a new face-to-face encounter. In this instance, supplemental documentation is not going to cover us, because the physician noted that the patient was all good, grand, and wonderful. So part of what CMS was doing what they wanted to do when they initiated the face-to-face encounter requirements was that they wanted to make sure that doctors are providing oversight, adequate oversight to each case for each patient. And I think a lot of what was happening for those of us that were in home health care prior to the face-to-face requirements is we would have patients that were referred for home health care that hadn't seen the doctor in 6 months. And if you think about it, I mean, you're truly homebound patients, they do have trouble getting out to the doctor. And when we have patients in rural areas, we don't always have visiting doctors who can go and see them. So we had this a lot, but CMS said, no, we need to ensure that the doctor is seeing the patient for the reason that they're referring for home health care. So let's go back to the patient that has an annual Medicare wellness visit. Everything is great, grand, and wonderful. They fall 3 to 4 weeks later. Ideally, as Charlie mentioned, we would get our face-to-face encounter information up front. But in this case, we probably don't want to delay admitting the patient. They are falling. They do need therapy. They do need safety assessment. We don't want them to fall again. So what we need to do is, most likely go ahead and admit, but immediately start working towards getting that patient to see that doctor so that the doctor can see the patient in a face-to-face situation. I think we are currently allowed to do that by video or by an in-person encounter, but we do need that, and we need the doctor to address the falls, the new onset weakness, any diagnoses that are potentially the cause of the fall, because as we know for PDGM, we cannot code falls as the primary, we cannot code weakness, we cannot code abnormal gait. So part of what we'd like the doctor to do whenever he sees the patient is say, hey, the patient is falling, and I believe that the contributing factor for this patient's falls is the arthritis of their knees or the spondylosis of their lumbar region of their spine. So we have to kind of factor all of that in to getting a new face-to-face encounter for that patient. Another example is when the primary diagnosis driving the home health frequency is not mentioned on the face-to-face encounter. And we see this a lot in home health care with wounds. And as we know, wounds is our highest paying primary PDGM diagnosis group. So when wound care is the focus of care, we don't want to have a misalignment that causes us to not be able to capture those wounds and capture that as the focus of care and leave a lot of money on the table. It can be as much as $800 for 30-day episode. So we really want to key into when we find wounds that aren't noted on our face-to-face encounter. This happens very frequently. Physicians don't always get patients up and check their entire body for a skin assessment. Things get overlooked when patients are in the hospital, or you have, a face-to-face encounter that's the discharge summary from the hospitalist, and a wound care specialist doctor saw the patient in the hospital, and it's not even mentioned on the discharge summary. So there's a lot of ways that lead into not having a face-to-face encounter that mentions wounds that either we knew about or maybe we didn't know about. The nursing or therapist gets to the home and we encounter wounds that are not mentioned on the face-to-face. When this happens, again, you're going to need a new face-to-face encounter. If you can find some documentation from the hospital or from the skilled nursing facility, from an allowed practitioner, so from a physician or a nurse practitioner or a PA, if you've got something, look at that, and is it comprehensive enough to be used as your face-to-face? If it is not, again, it may be necessary to get the patient to some sort of encounter situation, video or in person, where you can obtain a new face-to-face. But if wounds are your focus of care, you will need some sort of face-to-face documentation where a physician has seen those wounds, addressed those wounds, and mentioned that the wounds are ongoing and that there is a need for home health care. The next example is when the acute, active, or new diagnosis noted in the face-to-face encounter has resolved prior to the home health admission, and there are no other acute, active, new diagnoses noted in the encounter. So we talked about earlier the patient with the UTI that resolved, but in that instance, the face-to-face encounter also said that the CHF had been a problem. We were good there. Let's have that same situation where a patient is hospitalized with pneumonia that resolves. But our encounter, we're going to say we're using our discharge summary, for instance, says that everything else was great, grand, and wonderful. It was well controlled while the patient was in the hospital, and there were no issues with any of the patient's other diagnoses. In that case, we have a problem. In home health care, we are not allowed to code resolved conditions. So if the physician states that pneumonia is resolved, that's off the table. We can't code that. We now have to find what is our reason for seeing that patient. Is there a coexisting COPD? Is there a coexisting bone or joint condition that is contributing to weakness, and that is combined with post-hospitalization weakness? Why are we seeing that patient? And the second part of that is that we need to communicate with the physician and ensure that we get a face-to-face encounter that aligns with the diagnosis for which we are seeing the patient, that is an active condition, not a resolved condition. One of the things that we hear a lot on the coding and OASIS side is that we can continue to code resolved conditions if they are causing residual deficits. There are some conditions, for instance, COVID, that if the physician specifically documents there is a residual deficit, then that is acceptable to be coded even after the acute condition resolves. However, things like pneumonia and UTI, if the physician has stated that those are resolved, even if we think that weakness later on is a result of that UTI or that pneumonia, we can't make that assumption and we can't code resolve conditions. So it's very important to look at whatever document you're using as your face-to-face, especially on your hospital discharge summaries, and make sure that on that discharge summary, if the doctor has noted the acute conditions have resolved, that you're looking to see if there's something else listed there that can be your focus of care for home health care, and that's noted as being either new, acute, that there's a knowledge deficit, that there's a change in treatment, but something that is more than just standard or routine. The next common issue that we find is that the acute, active, or new diagnoses noted on the face-to-face encounter have resolved prior to the home health admission. Oh, I apologize, that's a duplicate slide. The next issue is that the face-to-face encounter is old and does not support the home health focus of care. And Charlie definitely talked about this in several different ways. One way being that we mentioned earlier, again, is when you have like a Medicare wellness visit or some type of just checkup visit or follow-up visit that doesn't mention any acute issues, and it looks like there's no need for home health care. Another one is when you've had a patient that's in a hospital and they go to a rehab and things have changed during the rehab stay, but you don't have any evidence of that. Or when they were in the hospital, again, they had an acute condition that's likely resolved by the time you admit them 21, 30, 90 days later to home health care. So we need to make sure that if we're using older documentation, and if we're using older documentation, that it is relevant to what we're seeing the patient for in home health care. It has to be relevant to the focus of care. Yes, in some situations, you can use a hospital face-to-face encounter even after the patient has been to a skilled nursing facility. That is possible, and that will work, and you won't always get an audit for it. However, because of that verbiage about it the patient needing to be admitted directly, you're always running that risk that an auditor can use that admitted directly verbiage to reject that older face-to-face. So if possible, getting the SNF discharge summary when you have those hospital to SNF patients is going to be much more appropriate and make your charts more audit proof than using the hospital summary. And that's especially true if anything has changed or is different. If it's not just absolutely aligning, you're going to be throwing up flags if you're not including documentation for what that kind of outlines what happened during that skilled nursing facility stay. In the event that you have an encounter that was completed prior to the home health start of care, and the encounter note is from your orthopedic physician, for instance, stating that the patient is scheduled for upcoming joint surgery. So I don't think we specifically talked about this one yet, but basically you have an H&P from an orthopedic physician. It says that the patient has OA of the knee or the hip or the shoulder, and they're scheduled for upcoming surgery. And then we admit the patient immediately following that surgery. We typically are seeing, or I won't say typically, but we are seeing many rejections now and non-affirmations due to the fact that a preoperative note is used and not a post-operative note. The preoperative note says that the patient is scheduled to have surgery. There's no proof there that the patient had the surgery. The preoperative note does not state the patient's status after surgery. It doesn't outline the need for home health care after surgery. So what we need to do as agencies when we have the preoperative note is that we also need to get a post-operative assessment of the patient to stand as our face-to-face. And that assessment will outline the patient's condition after surgery, that they have had the surgery, and that there is something that leads to the need for home health care after the surgery. The big one, I think that a lot of us are seeing now is this issue with that the preoperative note will no longer stand in all situations. And again, you may be receiving affirmations where you are using the preoperative note. You may be receiving, doing some TPEs and ADRs where you're not having a problem with the preoperative note. However, best practice is that you need to get that post-operative note. There's always that chance that you're going to have that different auditor that's going to hold you to these standards. The next common issue with the alignment of the primary diagnosis of the face-to-face and the encounter is that the face-to-face encounter is old and contains acute diagnoses that are questionably ongoing without other acute or exacerbated diagnoses. So we've talked about this one a little bit, and going just in a little more detail, this is the situation where you have the acute UTI, you have the pneumonia, and the patient has that, and then there's this gap in between the time that what you want to use as the face-to-face was done and the time that you admit the patient. And because you've got that gap and it's not an immediate admission to home health care, there may be a question about whether or not acute, especially acute infections, are ongoing. So again, we want to make sure that we have proper documentation, and we may need a new face-to-face encounter. If it is an ongoing diagnosis, sometimes a physician query in this instance will work, but not always. So really doing your due diligence and make sure that you're painting a good picture with physician confirmation, either by the face-to-face or by physician query, that your diagnoses are ongoing. The next common issue that we see is that the face-to-face encounter the face-to-face encounter notes that the acute diagnosis or diagnoses, and they are not PDGM acceptable. So this is one that hopefully we're more and more working with our physicians to get them to those PDGM acceptable diagnoses, but we do still see this fairly often. So for instance, the face-to-face encounter notes abnormal gait, weakness, and falls, and the patient has an active diagnosis of DJD of the knees, but it is noted as being stable. It's just listed in a diagnosis list. It's not listed as being related to the falls, the weakness, or the abnormality of gait. What the agency needs to do in that case, again, is we can query the physician and document that query and document that confirmation that the physician has confirmed that, for instance, the DJD of the knees is related to the face-to-face, or I'm sorry, is related to the weakness, the abnormal gait, or the falls. And that documentation will need to be submitted as supplemental documentation. The other thing that you could do, of course, is have another face-to-face where the physician addresses more thoroughly that these are the causes. But in this instance, you can get by with a query and confirmation and appropriate documentation, supplemental documentation that the physician has linked the conditions. Go back. And I'm going to turn it back over to Charlie, but before we do that, we do have another poll question for you. So if you want to take a few seconds to fill out that poll question, it should be popping up now.
All right. Thank you, Robbie. That was great. Very helpful for talking about focus of care. So hopefully everyone's had a chance to answer those poll questions. Leads us kind of into our next area here to discuss is about ADRs. Face-to-face is still one of the most common reasons for denials with ADRs. TP has been on hold due to the public health emergency, but now there are post-claim reviews happening. So there is a likelihood that there will be denials that occur. Palmetto indicated from January through March 2020, face-to-face requirements not being met was the #2 reason for the denial. Their #1 was simply the records not being submitted. So take that out, face-to-face is the top one. So when you do submit there, Palmetto indicated face-to-face is the #1 reason for the denials. CGS had reviews from October through December of 2020, and the #1 reason for the medical review, the denial, was the face-to-face was missing, incomplete, or untimely. This is kind of a blanket statement. That could be that either it wasn't there, wasn't signed, dated, didn't address the focus of care, but something related to the face-to-face led to a denial. NGS, they didn't have any of their stats readily available. But with 2 of the 3 MACs, they're reporting face-to-face as a #1 or a #2. It's a likelihood that NGS has a similar one. So again, to just kind of drive home, it is really key to get this right as much as you can up front. Make sure that your staff understand the importance of face-to-face. So how do we do this to ensure the compliance? So few areas here: educate intake staff on making sure they understand the face-to-face requirements. Make sure they know what they're having a look at if They are the ones that are going to review that referral. Most often it is them. Make sure they know what they're having a look at, what is required there, what must be present, and then it also allows them to go back to the referral source to ask for additional information or to clarify what may be needed. Additionally, educate the intake staff on coding, just so they have a basic understanding of coding conventions and guidelines, as well as PDGM, so they can really understand how important it is to get adequate information right at the point of referral. This allows for timely and accurate coding. It's helpful not just for those folks, but for the clinicians in the field to make sure they know why they're heading into the home. So making sure your intake staff are usually the first point of contact that a referral source has with your agency. Make sure intake knows what they need to ask for and what they're having a look at. As far as the field staff, making sure that they understand the face-to-face requirements, specifically about the importance of working with the patients and caregivers of the family to get that visit, if it hadn't occurred before the start of care, to schedule it and to keep it within the 30 days after the start of care. A lot of agencies that we work with, their staff, they've heard of it, but they're not really sure of what the impact is. Make sure they understand that impact, that it must be done within the 30 days after the start of care, and provide them the tools and the resources there to make sure it gets done, whether it's working with visiting physician groups, getting folks involved to help with transportation, making sure the staff know when to escalate that up to a manager or supervisor to have them intervene. And then additionally, make sure that the field staff understand the coding, again, the conventions, the guidelines there, and really how coding, plan of care, face-to-face, how all of this must align to allow for timely and accurate billing, to decrease the risk of a denial of claims, decrease the denial from RCD, and really so they understand the impact that their documenting has on the whole process, making sure they clearly indicate the focus of care, why they're out there, what is the skill need, and a thorough assessment to really help with the coding team. And then if anything else must be obtained as well to clarify any of the diagnoses that may not have been present up front. Then a few other items here. If possible, if you're part of a system, working with your referral sources to see if intake's able to access the EMR. This allows intake staff to pull down what they need. If you're part of a system, you may have access to your hospital's EMR, and it allows you to kind of pull down what you may need at that point. If that's not able to be done, make sure that your intake staff have a list of the documents that they will need, and this would include most recent progress notes, discharge summary, or any of the consult notes. Like we said earlier, H&Ps, they can be accepted, but it really should be a last resort if there are no other notes available. And then utilize health information exchanges as much as possible. If you have a referral source that uploads a lot of information into these, you may want to consider having access there, because this way, again, your team is able to hop in there, pull down the notes that they need, and make sure that gets out to your team. And then the last thing here, make sure the date of the net counter is included on the plan of care. We addressed this a little bit at the beginning, but this is such a key thing that we've seen a lot of the claims that are denied only because this doesn't happen, or there's a second form that is then sent out and it must be tracked. So make sure there's a process in place to identify the appropriate encounter, note that in the EMR, whether it's in a communication note or there's an actual face-to-face console or area to document within your EMR, putting that data in there so everyone is aware where to look, how to get that data, making sure it goes on the plan of care. Then finally, a final review of the plan of care should be done before it is sent out, making sure that it has this date on there, but making sure the diagnoses also will align with the face-to-face as well. These are really key things, making sure that you're compliant in this way. All this should help you to be compliant then, and making sure that what you got from the face-to-face, it does meet all the criteria. So it looks like we do have some time, so we'll go into the Q&A. I do want to have up here the contact information for myself as well as Robbie. Thank you, everyone. We'll have a look at these questions here and see how many of these we are able to answer. So we have our first one. Talk a little bit about ICD codes and how they align with justification for home health and its necessity. Robbie, I think, had addressed this a bit. There are some ICD codes that under PDGM are not acceptable, but most of them are. And it's really making sure that you're coding there, making sure you have all the adequate documents there to code, and making sure it is supported in that face-to-face, making sure that that document does align with what you will code and with what that clinical staff member noted in the field as going to be that focus of care. Our next question was, if they are discharged from a facility and we have the facility and discharge note and or admission note, do we still need the MD note from after admission from a PCP? The PCP follows the care, not the MD from the facility. So if you have that note from the facility and it meets all the requirements, it occurred within the 90 days prior, it's signed, dated, supports the skill need, homebound, and is related to the focus of care, that's fine. You just have to include that date. So the certifying MD, in this case, it sounds like it would be the PCP, they would have to indicate the date. So include that date on the plan of care. When they sign that plan of care, they've attested to the date of it. If they are scheduled to follow up with their PCP afterwards, it certainly doesn't help to ask for that note, to have it in your record to see if anything had changed, but your face-to-face, as long as the note from the facility meets all those criteria, you should be fine. The next one asks, is there any sort of document that exists that outlines state requirements that allow or disallows for NPPs to oversee and sign a certified home health plan of care and perform face-to-face? California allows for the NPP to now oversee the plan of care, certify patient eligibility for home health. At this point, it's still based on the states and their scope and their state practice acts. To my knowledge, I'm not aware of a database that outlines all of these items, so it would need to be within each state's practice act. Next question asked, many discharge summaries don't include a physician assessment. Can they still be used as face-to-face? That would be a questionable one. I've seen several ADRs that were denied simply because the assessment was not on there. If you do have that discharge summary without the assessment, what I recommend is if you can, have a look at the note prior to see if that will meet everything. If so, then you're good there. If you're going through all these notes and it's not there, you may want to consider having a supplementary note, whether it's a therapy note to support that, but the physician would have to sign off on that, and also schedule the patient to have a visit with their community physician ASAP after the start of care and utilize that note. Most of the time, the EMRs from the hospitals are pretty good that they have those notes, but if there's not an assessment there, I would try to find a note that has one, as it could result in a denial. Next question asked, patients transferred from a hospital to a SNF, then home, do not have an encounter with an allowed provider while in the SNF. Is it okay to use the hospital discharge summary for the face-to-face? when this occurs, or does the patient need to see a provider within 30 days? So like Robbie had said, was this may get through the chart, it may not get pulled, you may have an RCD app for information on it, but a reviewer could have a look at that and say, you used a hospital note, but the patient was not a direct admission to home health from the hospital, so it could result in a denial. To be on the cautious side, I would recommend the patient see the physician within 30 days of the start of care, and then you use that note just to make sure that you're covered there, because that hospital note very well may not be related to the focus of care, depending on how long the patient was in the SNF. The next question asked, does a note from an office visit that is used for the face-to-face have to say that the plan is for home health? We see a lot where any random face-to-face visit is used if it's within the time frame, even if there is nothing in the note that indicates a need for home health. So the office note, it doesn't necessarily have to say home health. It's helpful, but it doesn't have to. There should be an additional order that refers the patient to home health. Most often in the physician notes, they're one and the same, but at times it won't be. You'll get a separate order that says home health, SN for med management and wound care, PT for strengthening and ambulation. And then the physician's corresponding note should support that the patient is on a new med, has a wound, the patient is weak, they have balance issues. So it doesn't have to explicitly say home health for ABC on the counter note. It just has to support the need for it. And then what is the indication that the acute condition resolved, a code change, something in the encounter note? So that's probably a coding one that, Robbie, I'm not sure if you're able to address this one.
Yes, let me just read it again. What is the indication that the acute condition is resolved, a code change, something in the encounter note? So it could be a couple of things. Many times it's that the physician will say that the condition has resolved. And if the physician says that the condition has resolved, then that's it's non-negotiable. Basically, it is resolved if the physician says it is. That's for any condition, which sometimes you'll even have situations where physicians say that chronic conditions like diabetes have resolved. But if the physician says it's resolved, we can query them if we question that. But we do, if we take it on face value and we don't query and follow up, then it is resolved. And then the other situation is where you have a condition that is typically in all supporting documentation leads you to believe it is a very acute condition, and a significant amount of time has passed between the time that the doctor said the patient had this condition and the time that we admit for home health. And in that case, yes, sometimes you can code it and nobody will ever question it, but there are also times when it does get questioned. And so you need to look at the acuity of that condition, how long of a time has passed, and is reasonably, would we think that this condition is still ongoing or not? And just make sure that we have any documentation that we need to back up that it is ongoing, or query the physician, and if the physician says that it's resolved, then again, it's resolved.
Great. Thanks, Robbie.
I think the next one is probably for me also. Is there an accepted standard for a physician query regarding diagnosis? There is. I will tell you one of the best places that I use and that I refer people to. If you Google, AHIMA has an article with an example of a verbal physician query and how that should be documented, as well as many written physician queries that you can send to the physician. So there are a number of good examples on that AHIMA article. If you Google physician query examples, that will come up, and look at that. But the biggest thing with a physician query is that we are not allowed to lead the physician. So we have to kind of leave it open-ended. We have to give them other options and show that we did ask them, they did confirm, but that we did not lead them into a diagnosis. All right, Charlie.
All right. Thank you very much. So we got about a minute left here, going down this list. Question was, is it feasible, acceptable for the provider to annotate their encounter? That is, add a note saying something like, I did not note it at the time, but the arthritis is out of control and therapy and pain management at home are required, handwritten on a document by someone and signed in the data by the provider. Is that an acceptable method to obtain complete face-to-face? A physician can annotate their visit note, but again, is kind of what guidance were they giving? If we're calling them and saying, hey, your note doesn't have an assessment here, they may say, oh, I overlooked that. Maybe they'll adjust it then and send it back. So as long as that final claim has not been submitted, you can still use that note. The physician only has to use acceptable guidelines on how to annotate a visit note. So they would put that note in there, then sign and date that note afterwards to indicate that it was an annotation. So with that, we have reached time. It is 2 o'clock. I want to say thank you to everyone. Sorry if we did not get to your question. We will try to pull these down, reach out, and respond via an email with a response. If there are any questions that you have, feel free to reach out to myself or Robbie. We're happy to help you out. Thank you again, everyone.